I'm sure you all do elastic nailing in femur in children since quite some time now. But even then, we find that there are a lot of errors and mistakes that people do make in their technique. So we've just put together a small presentation called 10 commandments for tens in the femur, which I'll go through. So the first commandment for elastic nailing in children for femur is first is thou shalt understand the concept of tens. Now, when you say concept of tens, most of the people ask us that they have been doing rush pins, enders nails for so many years. And they are elastic nails. So how come you are talking of tens and what is the different concept here? Is there some real conceptual difference or it's just one new implant which has been brought into the market? If you look at this safety pin, actually it's just a stainless steel wire which has been coiled such that there is a spring action at one end and then there is a clasp at the other end. Now this stainless steel wire, when it is bent and secured at both the ends, it creates a tensile strength, right, which gives it the ability to hold up or pin objects. Similarly, an elastic nailing concept is a different concept compared to enders, where you just stack the canal with one nail, second nail, third nail. So that is a canal filling concept. Whereas this gives elastic stability, right? Because of tension created between the two bent ends of the stainless steel wire loop. So I'll just explain with an animation the same thing. So we have two pre-bent elastic nails which are inserted from either side from the dense metaphyseal bone. The bending of the nail is such that it is more than what the canal can easily accommodate, which creates an elastic recoil within the bone, and two nails of the equal diameter inserted from either side will then create a tension within the bone which stabilizes the fracture. So just look at this animation. The yellow here is the bone, this is the fracture, and you have this elastic nail with you, okay, the titanium elastic nail, which is the black line. Now you bend it to such an extent that when you put it in bone, it deforms bone, right? The bone actually deforms because the elastic nail is trying to straighten out. Now, if you put another nail which is pre-bent in the same amount from the opposite side, both of these elastic nails will create a sort of a spindle. And this spindle gives an excellent 6-point fixation. And that gives an elastic stability, which under moving conditions creates sufficient early callus with no requirement of a plaster. So the concept of an elastic nailing system itself is different. It is not the same as putting a rush nail or not the same as putting endless nail. So it's technically a more superior biomechanical concept. The second commandment is thou shalt choose the correct indication, right? You know the tool, but your indication should also be right. So what is the correct indication for elastic nailing? Classical indications for elastic nailing would be a mid-diaphyseal fracture, right? Can you see this now, Ashok?
Yeah, I can. We can.
Yeah. Okay. So it's a mid-diaphyseal fracture, which is transverse, short oblique, or a short spiral with minimal comminution. And the ideal indication is between a 5 to 12-year-old child who does not weigh more than 50 kilograms. Because more than 50 kilograms, the elastic nailing system has been found to be a little mechanically unstable and can cause bending or deformation. The classical indications are, as I said, transverse fractures in the middle third between 5 and 12 years, which can be nailed thus without any plaster support. And extended indications or relative indications are where you can use it in subtrochanteric or supracondylar fractures, but with a little modification of technique, which you will understand as you go along. Comminution actually is a contraindication, but we can bypass that by making some modifications, which I will talk about eventually. The third important commandment is thou shalt understand the nail and follow the proper bending principles. So what is this commandment? First, it starts with the nail size, right? The nail size, if it is too thin, it will pass very easily, but it will not give any stability. If you make it too thick, it is difficult to negotiate and becomes very stiff. So what should be the rule? The rule is that your nail should be 40% of the canal diameter at the isthmus. So the narrowest diameter should be measured and multiply that by 0.4, which is 40%. And each nail is 40%. So total, both of them comprise 80% of the canal diameter, which gives the perfect elastic stability. So measure the inner canal diameter, multiply it by 0.4. This is the choice of your nail. So you will choose a nail which is 40% inner diameter. How can you do that? Keep a nail on the patient's thigh, take a C-arm shoot, and make it put it from the entry, the metaphyseal region, to the intertrochanteric line, where is the final seating position, and see how much two nails occupy the canal. You should see a thin line of the canal outside the nail margins, which means that you are roughly right, and you should choose a nail accordingly. As a rule of thumb, the femur usually will take 3.5 or 4 mm. Tibia takes 2.5, 3 or 3.5. The humerus and forearm take between 2 and 3 millimeters. So this is a standard sizing which you will see in children between this age group. If you don't choose same size nails, so the second part of this choice of nail is you should always have same choice of nail. If you see there is a different size of nail, then the tensile forces are different. So the bone will bend on one side and create a deformity. So you must have a situation where both nails are equal diameter to balance out each other's forces. The next question is, how much do you bend? So again, the inner diameter comes to our rescue. So if the inner diameter is about 8 millimeters, then you will multiply it by 4, and that is your bend of the nail, right? So the apex of the bend. So your choice of the nail is 40%, and the apex of the bend is going to be 3 times the inner diameter, right? So you choose the nail 0.4 into D and bend the nail 3 into D. So 8 millimeter nail, the apex of the bend will be 24 millimeters, right? So just to show you that, this is the straight nail, this is the apex of the bend. The apex of the bend should be 3 times the inner diameter. This is the amount of bend which is optimal for giving the optimal recoil for an elastic nail. The next point is, where should be the bend? So the apex of the bend should come exactly at the fracture side, right? If the apex of the bend is not at the fracture, you see that the spindle is not formed at the fracture. So what happens is that this creates relative instability, and that will not succeed. So the bending has to be exactly at the fracture apex. The height of the bend should be 3 times the diameter, and the size of the nail should be 0.4 into the diameter. So these are the nail and bending principles which you should know, so that your nail spindle is perfect. An example here, the artery forceps is showing you the apex where the bend should be, and then you bend it 3 times the inner diameter. That is how you choose it, and then the apex is bent exactly there. This is the nail chosen. Now this nail should be bent equally on both sides of the apex. The rest of the nail need not be bent. So it is not that you have to bend the whole nail. The rest of the nail can be straight and it need not be bent, but equal bend on both sides depending on the apex of the bend. Symmetrical bending can be achieved with the use of these wire benders or plate benders if you have available, or there is a handheld tool which you can use to bend the nails. But make sure that you are bending symmetrically, right? So these are examples. Now the medial nail is always a little longer because it goes to the neck region and it is bent on a longer arc of diameter. Okay, just remember that the medial nail bending is usually more because it's bent more because it goes in more, right? Second, you must have smooth bending on either side. So bending should be starting from the apex and proceed symmetrically on either side. Don't bend at the ends too much and very little in the middle, right? So bend at the apex first and then smooth curves on either side so that it forms a uniform arc, right? Uniform bending will give you excellent recoil. The fourth commandment is that don't be very conservative with your entry points. Thou shalt make an adequate entry so that you don't struggle. The medial entry should be about 2 finger breadths proximal to the superior pole of the patella. On either side, you can have a symmetric entry point. You can pass a K-wire and drill over it, right? Something like this. So you enter with a straight awl and then make an adequate channel with a curved awl to enter the canal adequately, right, from both the sides. So a symmetrical entry point about 2 finger breadths proximal to the physis, which lies at the superior pole of the patella as a surface marking guide. Now, if you don't do that, if the entry point is not right, you can end up having a nail which rotates or is placed too anterior, and that irritates the synovial pouch. So irritation of the suprapatellar pouch, nail which backs out, if it is not adequate, may cause irritation of ligament. Finally, the nail should be sufficiently away from the growth plate. Now see this nail, this has been placed, this is an Ender's nail, it has not followed any of the principles. A single nail has been passed, which has created a valgus deformity in the fracture site, plus the tip of the nail sat on the physis and irritated the physis, which got infected, and you can see a growth arrest there, plus a femoral inefficient valgus. So both the principles have been violated. There is no symmetrical nail balancing force here, and the nail has been inserted too close to the physis. So these things should be avoided. Another example where somebody has put Ender's nails again, but the tip is lying on the physis, and this has worked like a growth modulation tool. It has actually reduced the growth on one side because the nail tip obstructed the pericondylar blood supply to the physis here and resulted in a valgus deformity. Right? So you can get growth related issues if you don't put the nail correctly. Finally, distal entry is always preferred, because if you put the nail from proximal side here, you can see 2 Ender's nails being passed here. They have gone through the pyriform fossa, which puts the head at risk because the lateral cervical ascending artery comes from here. You will cause avian, or you will damage the physis here. And in this patient, what happened is, it damaged the physis, it stopped growing and ended up with severe genuine. The 5th commandment that I wanted to speak about was how do you advance the nail in the canal. So the commandment 5 is thou shall advance the nail correctly. So when you enter the entry point where you have made the adequate entry point, your nail should go in the direction of the curve, right? So this is how you enter, rather than struggling by trying to push it in directly. Go with the curve into the canal first, then turn it around 180 degrees to face the medullary canal. Then you advance it slowly so that it bounces off the opposite cortex. Always use 2 chucks and never hammer the nail. If you are requiring hammering instead of your hand motion, probably something is going wrong. Okay, you will either perforate the cortex, or then your nail, your entry point is not adequate. You have not entered the canal at all. Right? So you should be able to pass the nail on either side, use both 2 chucks and go simultaneously. Never go one nail into the fracture site and across the fracture. Bring it to the fracture site. See, this is an example of snaking due to severe rotation. Sometimes you keep on rotating the nail in an attempt, and then you get a spiraling like this. This is called snaking. And this is not healthy because it takes away the spindle and creates instability. The 6th commandment is that thou shall use proper reduction maneuvers to get your reduction before you pass the nail across. People who use fracture table can use traction and distract the fracture a little bit so that it is easy to pass the nail. But sometimes it becomes difficult to put a small child on a fracture table. The fracture tables that are available are usually adult fracture tables. And I personally don't use a fracture table. I use a radiolucent table on which we use manual traction with a small pillow or a small bolster under the thigh so that the anterior bow of the femur is restored. Okay? And with that, you can also use a reduction tool. This is called the F tool or the reduction tool, with which you can maneuver the fragment into procurvatum, recurvatum, or varus or valgus as you get your reduction. After that, pass always the first nail that easily goes into across the fracture. Sometimes you can use a joystick maneuver, use a pin. You can see this pin being used to push the fragment opposite side, so that it creates an appropriate angle for the nail to enter the proximal side. Right? Use that hockey stick bend so that you can maneuver the tip into the opposite diameter canal and engage it before you turn it around. So always use these small tips and tricks. Use a K-wire, use the hockey stick bend, use the F tool and get your reduction. Get one nail across first before you pass the second nail. The seventh commandment is that thou shalt maintain the length of the femur at all times, which is why we said that the comminuted fractures are not such a good idea. Now, see this fracture. You have a long spiral here with some combination and 3.5 mm nails have been passed. The nail placement intertrochanteric is good, but the nature of the fracture is such that it collapses. So this is not a length stable fracture. Transverse fractures, short oblique fractures are length stable. And over a period of time, because of the collapse, you see that the nails have backed out or protruded. So long spirals, there is a chance that you may end up with backing of the nails because this is not length stable configuration. So what can be done for this? AO provides these end caps. So these are threaded diameter specific caps which can be used to plug or block your nail at the entry point so that it doesn't back off, and it gives a more secure fixation like an interlocking screw so that the length is maintained. So this is an example of a long spiral fracture here. Again, use of two nails, a nice spindle here, but perfect use of end cap so that this cannot back off. Because it cannot back off, then the length is maintained and it goes on to a satisfactory callus end. So end caps will give you length stability. Remember that. If you don't have an end cap, what I prefer to do is in this particular comminuted fracture, you can see we pass the nails and we maintain length with the use of an external fixator. So a couple of pins here and couple of pins in the distal fragment. All that comminuted fragments have been bypassed using elastic nails and put the fixator so that there is no collapse. In about 4 weeks, you can see that there is callus formation. The fixator comes off, your length is maintained once the callus starts hardening. And then the nails take over as internal splints. So completely closed procedure, even in bad comminuted fractures, we have been able to do closed nailing, closed external fixator, use the biology for a biological healing, protect it with a brace later, and this is how it healed and remodeled beautifully. That is at implant removal with full range of motion. So it's not that the fixator created any stiffness or muscle fibrosis. It's a temporary fixator. You can use even a Jess fixator and keep it on for 3 to 4 weeks just to maintain length so that callus forms, and then you remove the fixator and go to the nail as a stability tool. Commandment 8 is thou shalt seat the nails flush. As an orthopedic surgeon, we have this tendency of bending the KO as right angle and resist that temptation in elastic nails. Because what happens is that in elastic nailing, we are not supposed to bend the nails at right angles because we'll end up creating synovial irritation. Ashok, we are stuck again.
Okay.
Slide not advancing.
Okay, just a minute, sir.
Yeah, okay. Now, okay, we went ahead.
Yeah.
Okay, so you can see here, if you don't seat the nails flush, you get recurrent effusions like these. Okay, end of the nail can cause soft tissue irritation, especially if the nail is pointing anteriorly or if it rotates anteriorly secondarily. So right angle bend of the nail is a very bad idea. You should have the nail flush with the cortex. And this is a special tool available in the set, which is the final seating tamp, by which you can push the nail in such that 1 centimeter remains parallel to the cortex here, right? So it doesn't really sink it in, it remains outside. About a centimeter is available to you outside, but flush with the cortex. Don't make a right angle curve. 9th commandment is thou shalt check rotations before final seating. Now see this X-ray. A transverse fracture which has been fixed with elastic nails. Satisfactory healing is seen, but the mother says that she is not walking well. She walks crooked. And when you examine the child, you find that there is you can see this external rotation on this side and opposite side where the surgery is being done, too much of internal rotation and less of external rotation. So what has happened is that, but in a transverse fracture, you can end up having 45 to 90 degree malrotation and you will never make out on the CR because the fracture alignment will look perfect. So it's always important at the end of the surgery to check rotations. especially with transverse fractures, so that you make out that there is no malrotation which can cause a problem. If there is a malrotation, you will need to withdraw the nail, turn the fragment around. Now, X-ray, if you see, this shows AP here and lateral on the proximal side. So this is mal-rotated by 90 degrees. And finally, removal of implant is a big issue because most of the times the parents or the patient wants that implant removed. You should remove implant in the femur after 6 months, preferably less than 18 months. Forearm fractures, you can remove it later because it takes longer to heal. When you remove the nail, as I said, the nail has to be flush a centimeter out. Use a small periosteum elevator. Get under the nail so that you can hold it with a wrench or a plier. Special extractors are available in the AO set which have a sharp fin against which you can hammer, and these are locking clamps. If you don't have this, what I prefer to do, I'll just show you. Ashok, again, can you help me with the slide?
Yeah.
I'm not able to go ahead. Yeah. So I'll just show you this small video here. Okay, we have to go back.
Okay.
Oh, we are going in front.
Yeah.
Yeah. So this is a small video which I wanted you to see. Everybody in their hospital will have a hollow mill, right? So I'll just show you what I do with the hollow mill. Right? You can see the nail tip here. This is a femur nail that I am removing. That's the nail tip flush with the cortex. So just insert a hollow mill, bend the nail 90 degrees. Once you bend the nail, your plier can grip it very well. Okay? And then you can backhammer it. Because it's a small area there and it's very difficult to hold a nail. It becomes so easy. Right? I'll run this again for you. The nail 1 centimeter is usually left outside flush with the cortex. You can see that here. After exposing it, just pass a small hollow mill around that, right? Against the cortex, turn it 90 degrees. You will be able to do that. And then you will be able to hold it with a plier at 90 degrees and then backhammer it. Sometimes holding it with the tip becomes very, very difficult and it keeps on slipping. So this is a small tip that you can do. And final, this is my commandment. If you're not comfortable or confident or not trained in using elastic nails, do what is comfortable for you, including plating or spica. It's not mandatory that every child needs to. A badly fixed fracture is worse than conservative treatment. So conservative treatment always works provided you maintain length, rotation, right, and alignment. Length, alignment, rotation, LAR. Remember those. But for a 5-year-old to 12-year-old less than 50 kilograms, ideal indication, elastic nails today are gold standard and they work beautifully well.